Okay, we're going to go ahead and get started. I apologize for the delay, but this time of the year, when we're trying to get things done, I had to grab the reviser before I got him in here. So, first order of business is we're going to open up the hearing on House Bill 2288, enacting the counseling compact to provide for interstate practice privileges for professional counselors. And we'll hear from Reviser Abbott.
Thank you, Madam Chair, and good afternoon, committee. House Bill 2288 was sponsored by this committee. For those of you who have seen compacts before, this is going to look very similar to any other compact you've ever seen. Essentially, it provides interstate practice privileges for professional counselors among member states to the compact. So essentially, it sets a minimum requirement of licensure standards for member states to meet for professional counselors. And if a member state meets those requirements and is a member of the compact by their legislature having enacted it into law, then a person who is licensed in one state with a home state license among those members may practice interstate in the other member states, referred to as remote states for purposes of the compact. Like any other compact, it has a lot of mechanisms that are very similar to other compacts, establishing an interstate commission that is authorized by the compact to adopt regulations that govern kind of its own procedures, proceedings, matters that come before that interstate body. Each member state gets membership on that interstate commission and is able to adopt rules to kind of govern the general procedures that it's charged with. So this compact is already in effect. The compact text provides that it became effective when the 10th state enacted it into law. The 10th state was Nebraska on August 19th of 2022. According to the compact's website, Delaware was the most recent and 17th state to enact the compact on August 4th of 2022. The compact has been enacted in Nebraska and Colorado. It is currently pending before the legislatures of Missouri and Oklahoma, just to give you some context of surrounding states and where they stand on the issue of this compact. The compact for the state of Kansas, if enacted, as other bills, would take effect upon publication in the statute book, so July 1 of this year. Madam Chair, if there are specific questions about the mechanics of the compact or compacts generally, I'd be happy to answer them, but as I said, this is very similar to any other compact you might have ever seen before.
All right. Committee, any questions for Reviser Abbott on the bill? Representative Clifford.
Thank you, Madam Chair. We're dealing with a flaw in the compact for physical therapists. KBI won't allow us to do the background checks. Is there language in this to prevent that circus? Thank you.
Madam Chair, I have not analyzed the fingerprinting and background check language in this compact to compare it to the issues that have been raised by KBI and I believe also by the FBI in the issue of the processing of those background checks. I have not done the analysis of comparing them to see if the text of this compact has addressed those issues. As an interstate compact, of course, if we make changes that are substantive in nature, it kind of interacts and interferes with the operation of the compact in the member states that have already adopted it. So I would just kind of give that as way of background information. But at this time, I could not tell you if this addresses KBI's concerns.
Thank you. Thank you, Madam Chair.
Well, and I do believe that we have kind of a universal bill that is moving through, I believe it's judiciary, to address those concerns. And so it's kind of a blanket deal to address exactly the point that you're making, which means, and whatever these folks here have to do to correct the statutes, then that's up to the powers that be. But I think that gets fixed in that bill.
Thank you, Madam Chair.
Because it is a major concern. Committee, are there further questions? All right, seeing none, thank you, Scott. Appreciate it. All right, committee, first up to testify as a proponent, I have David Fye, Executive Director of the Kansas Behavioral Sciences Regulatory Board. Welcome back again. We didn't do enough to you yesterday? Come on.
Well, thank you, Madam Chair and members of the committee. I am David Fye. I'm the Executive Director for the Kansas Behavioral Sciences Regulatory Board. The board of the BSRB is supportive of this compact. I understand that this compact was requested on behalf of the Kansas Counseling Association, so I will speak broadly to the support of the compact for the board. But just as a reminder, the Behavioral Sciences Regulatory Board, or the BSRB, we are the state licensing agency that licenses most of the state's mental health professionals, including professional counselors, which would be covered under this compact. Just a little bit of background in terms of the number of individuals affected by this compact in Kansas. Currently, right now, the BSRB licenses 2 levels of individuals at the professional counseling profession. There is a clinical level, and then there is a lower level for individuals to be able to practice with supervision, and they can be obtaining hours towards that clinical level of licensure if they want to pursue a clinical level. But this compact would refer and relate to those individuals with a clinical level of license, and currently there are 1,088 individuals who are practicing in Kansas at the clinical level with that clinical professional counseling license. As the revisor mentioned earlier, this compact has been in the works for a few years now. It was passed by 2 different states, I believe Maryland and Georgia back in 2021, and then several others passed the compact last year. This is the first year the compact is before the Kansas Legislature. During the time that the compact has been going through the works with other states, back in 2021, the board and the Professional Counselor Advisory Committee that assists the work of the board, they had the opportunity to review this language and do research. Last fall, on August 1st, the Professional Counseling Advisory Committee received information from representatives from the American Counseling Association and also the Council on State Governments National Center for Interstate Compacts that were able to answer questions and provide a broad overview of this compact. On August 3rd, 2022, the Professional Counseling Advisory Committee voted to recommend to the full board of the BSRB support of this compact. And then the board received that recommendation on November 14th, did research on the compact, and on January 6th of this year, the board of the BSRB voted to support the compact if it was requested in front of the legislature this year. So the board is encouraged by the language and the model language that has to be passed by all states to join the compact. We believe this would be helpful in helping out with workforce issues without endangering public protection mission of the board. There are a couple of items that would probably need to be clarified as we work through this legislation. One is that currently there is no specified charge to the state to be a member of the compact, though the language in the bill itself does say that there can be a charge to states to be members of the compact. So that's a little unclear, but we don't expect that it would be a significant impact on revenues or expenditures to the state of Kansas. And secondly, concerning that issue and the topic of the background checks and fingerprinting, currently we do not require individuals with a license to undergo that type of fingerprinting and background checks, but there is language in this bill that would require that as one of the conditions for joining the compact, so that would need to be worked through in terms of us to be a member in the compact. So with that, just want to reiterate, the board is supportive of this compact and encourages your support of this bill as well. And I'll be happy to stand for any questions at the appropriate time.
All right. Thank you, David. Next I have is Laura testifying today or just here for questions? Laura Shaughnessy, board member of Kansas Behavioral Sciences Regulatory Board, virtual.
Madam Chair and members of the board, I'm on WebEx today. I'm sick, and so I want my words to stand, but I'm happy to answer questions. Thank you.
All right. Thank you very much, Laura.
Thank you.
All right. Next, we have Andrew Secor. Is that correct? Secor, President, Kansas Counseling Association. Welcome to committee.
Thank you. Madam Chair Landwehr, Vice Chair Epley, Ranking Minority Member Ruiz, and members of the House Health and Human Services Committee, thank you for the opportunity to speak before you today. I am Dr. Andrew Secor, and I am the president of the Kansas Counseling Association, and I am here speaking on behalf of the board of the Kansas Counseling Association as a proponent for HB 2288. The Kansas Counseling Association, which has served in Kansas since 1970 and advocates for over 2,000 professional counselors in the state, is also a member of the American Counseling Association, which is the largest counseling body serving professional counselors in the United States. The issue of counselor mobility and a client's ability to continue counseling moving outside their provider's service area is a well-known issue to Kansas counselors. Licensure laws and requirements make continuing care difficult beyond one's home state. A 2023 report on the state of mental health in the United States published by the Mental Health America ranked all 50 states and the District of Columbia based on their rates of mental illness as well as access to care. Kansas was ranked last in this report. In addition, when breaking it out, looking at adults and youth and other factors, we ranked last with adults, 50th in youth, as well as 48th in access to care overall, and also ranked 48th in suicidal ideation among adults. There's also the knowledge of the mental health workforce shortage. This report indicated that the national average was about one mental health provider to every 350 individuals. Kansas's ratio was 1 to 470, exceeding the national average. Enacting the compact would help address the workforce shortage in Kansas as well as access to care issues. Compacts are not unusual and are increasing in use to address issues of portability and access to care. Currently, PsyPact was enacted this past year for psychologists in Kansas. Also, nurses and physicians, physical therapists, as mentioned earlier, and other professions are also using these compacts. The Kansas Counseling Association supports the compact because it preserves existing licensure systems, enhances public safety through a shared interstate database of licensure and disciplinary information, improves access to professional counseling services, enhances mobility of professional counselors, supports relocating military spouses, improves continuity of care when clients travel or relocate. Currently, when people leave their area, normally they have to end services with their providers, and then they have to figure out a way to resume services in another state. Also, we have students that leave for college or come to Kansas for college that also requires them to end their services with one provider and then attempt to locate another provider in their home state, which can be challenging given the nature of a therapeutic relationship and the challenges of establishing such a relationship under those circumstances. It also offers greater control and ability to regulate the profession in the state, increases access to care for Kansas citizens as well as our rural individuals and also those near border states, and also gives Kansas a representative to the Commission that is already meeting to participate in discussions and decision-making around the compact. Besides those individuals already testing and as proponents today, we have support for the compact from various universities around the state of Kansas, including Kansas State University, Fort Hays State University, Wichita State University, and Mid-American Nazarene University. These are all counselor preparation programs and also agreed upon by their counseling faculty. We also have support from the National Career Development Association, the American Mental Health Counselors Association, and the American Association for State Counseling Boards. In addition, it was mentioned that 17 states have already enacted the legislation, including Colorado and Nebraska. 19 additional states have legislation pending at the present time, including states in our region, as mentioned, Oklahoma, also Arkansas, Missouri, Iowa, Minnesota, North Dakota, and also Wyoming. Kansas enacting this legislation would allow us to keep pace with the states that are already pursuing this legislation. It is imperative that Kansas takes this opportunity to address the issue of client access to care and provider practicability by joining the only viable, sustainable, and long-term solution. We respectfully request you support HB 2288 enacting the Counseling Compact. Thank you.
All right, thank you. We're going to take questions after everyone's testified. Appreciate it.
Thank you.
Next committee I have virtual is Dominique Marcelek. Is that correct? Government Affairs Specialist, American Counseling Association.
Yes, that's correct. Thank you.
Welcome.
Good afternoon, Chairperson Landwehr, Vice Chair Epley, Ranking Minority Member Ruse, and honorable members of the House Committee on Health and Human Services. My name is Dominique Marcelek, and I'm testifying on behalf of the American Counseling Association in support of HB 2288, which will allow Kansas to join the 17 states that have enacted the compact, as well as the 19 states that have introduced this legislative session. Founded in 1952, ACA is the world's largest association, exclusively representing over 62,000 professional counselors in all 50 states, including Kansas. The Counseling Compact utilizes a mutual recognition model of interstate practice, whereby compact member states agree to recognize valid licenses issued by other member states. To utilize the compact, a professional counselor must have a license in good standing in their home state, their primary state of residence, and the home state must be a member of the compact. When a licensee wants to work in another member state, they must obtain a privilege to practice from the Counseling Compact Commission, the public administrative entity composed of a state counseling board representative from each member state. Commission regulatory power is strictly confined to administration of the compact and does not interface or interfere in any way with individual state practice acts or a state scope of practice. A privilege to practice is simply an additional privilege that a Kansas counselor can opt into after being licensed by your state. The compact is not an alternate license nor pathway to licensure. It's an optional privilege for current licensees in your state. Furthermore, like single state licensure processes, counselors provided a privilege to practice must abide by the laws of the state they're practicing within, where their client is located. The Counseling Compact preserves the authority and sovereignty of each state through the existing state regulatory structure, unlike national licensure, which supersedes state authority. The compact is revenue and cost neutral. We do not anticipate substantial additional costs for the compact. It allows member states to offset nominal administrative costs by charging an appropriate fee for the privilege to practice. These fees will substantially reduce the cost of practice across state lines for counselors and it streamlines processing, thereby saving state boards further time and money. With these benefits in mind, the American Counseling Association is excited to endorse the Counseling Compact and urges your support in the passage of this critical legislation. Thank you.
Thank you very much, Dominique. I appreciate it. Was there anyone else that believed they had sent in testimony that I did not call upon? All right, seeing none. Committee, you do have written-only testimony from Sherry Crow, Department Chair, Fort Hays State University. Deneen Pennington, Executive Director, National Career Development Association. Todd Fry, Chair, Department of Counseling, Mid-American Nazarene University. Philip Mullins, Counseling Program Coordinator, Wichita State University. Claudia Tucker, Vice President, Government Affairs, Teladoc Health. And then we do have one neutral, which is also virtual, and that would be Carl Sims and Nahel Kloffuss. I know I've just butchered that. The Council of State Governments National Center for Interstate Compacts. Yeah, virtual. Are you with us?
Yes, thank you, Madam Chair and members of the committee. Thank you for your time today. My name is Carl Sims. I'm with the Council of State Governments National Center for Interstate Compacts. CSG provides nonpartisan membership support to three branches of state government, inclusive of interstate compacts, where we provide educational and informational services for the development and administration of compacts, inclusive of the Counseling Compact. Just to add a few notes to what already has been presented here in testimony, that one, interstate compacts are a reflection of how states currently license a given profession. So, for example, in counseling, this is reflective in those uniform standards of how states already license across the board. Also want to mention that the Counseling Compact, like other licensure compacts, leave in place the scope of practice. So anyone practicing within, in this case, Kansas, would have to abide by the laws and regulations of Kansas when they're practicing, and does not impact the initial pathways to licensure. In response to a few notes here regarding FBI background checks, I just want to note that this is an issue that is intermittent throughout compacts and across states, that there is some discrepancy about how FBI background checks are processed or not processed, given the requirements of the compact. That among other efforts, federal legislation has also been introduced to help address this issue. Most recently, the SHARE Act introduced late in 2022 as part of this. With regards to fee structures, those are determined by both the member states to charge their own fee, as well as the Compact Commission to charge for those privileges to practice, and are done so once those privileges to practice are available to practitioners who may qualify. I'm here to provide this neutral testimony, and it can help out with any technical questions that might arise that we can help out with. So thank you for the committee's time today.
Thank you very much. All right, committee, that concludes all of our testimony. Are there questions for any of the conferees? Everyone did an excellent job, so that's kind of amazing. I think, David, this is more of a comment. I think that You make a valid point on the fee charge piece, so I think we're going to, look at a small amendment on that and maybe come back in like we did with the psych pack to kind of fix that. Did you want to comment on that?
Just for the, to your point, with the SIPAC Commission, when the bill for the multi-state compact for licensed psychology was passed, there was an additional item that was added on. The language of the compacts can't be changed. It has to stay in the original form. The states are allowed some flexibility sometimes with additional items that relate to the compact language. And so for the licensed psychology compact, there was an assessment that was going to be charged to the state of Kansas at the end of every year based on how many individuals in Kansas were practicing under that compact. So there was some language added in that bill to join that compact that allowed the BSRB to essentially issue a fee to individuals practicing under SIPAC authority as a way for us to recoup some of that cost that we would be charged to be a member of that compact, essentially because of that assessment. And so that was what was done for that bill.
And I think it had a cap of 25.
Correct.
Yeah. Okay. So you'd be all right with that.
Without knowing what the amount would be for this compact, I think that would be sufficient for right now. If we were to find out in future years that it was excessive, we might revisit that topic, but I think that would be fine.
Okay. All right. Thank you. Committee, are there any questions or comments at all? All right. Seeing none, thank you to the conferees, and that closes the hearing on House Bill 2288. Now, committee, let's turn our attention to House Bill 2259 and open up that for hearing, providing that certain mental health medications be available without prior authorization to treat Medicaid recipients and abolishing the Mental Health Medication Advisory Committee. And we'll hear from Revisor Scott Abbott.
Thank you, Madam Chair, members of the committee. House Bill 2259 was sponsored by this committee, and I really don't have that much more to say than the chairwoman did about what the bill does. So the substance of the bill begins on page 3. This is a current law that governs the use of prior authorization for medications used to treat mental illness for Medicaid recipients. Currently, only medications that have gone through a review process by the Medicaid Drug Utilization Review Board and the Mental Health Medication Advisory Committee can be subject to prior authorization requirements for Medicaid recipients. The bill that originally put this into place also established the Mental Health Medication Advisory Committee in order to develop those guidelines for those drugs. So what the bill would do would simply prohibit the use of prior authorization or other restrictions on medications used to treat mental illness. It would also specify a number of classes of drugs that would be included by way of illustration, but would apply to all medications used to treat mental illnesses. It would also dismantle the Mental Health Medication Advisory Committee because this is the only charge they are given by law is to perform this review function. So if you take away this review function, there is no purpose in statute left for that body. So it would be abolished. And so the bill would simply clean up the statutes to remove or clarify references to that body. The bill would take effect upon publication in the statute book.
Committee, are there questions for Revisor Abbott? Seeing none, thank you. Oh, wait a minute, excuse me. Representing Barth.
Thank you, Madam Chair. With the, my question for you would be, Scott, is with the dismantling of that review board, does that actually give us a positive fiscal note then, or is there a cost to that currently?
Madam Chair, Representative, I can't speak to the fiscal note. The fiscal note is prepared by the Division of the Budget in consultation with the agency, so I can't speak to what's in that.
I haven't looked that up yet. Thank you.
Committee, are there further questions for Revisor Abbott? All right, seeing none. Thank you very much, Scott. All right, committee, we have as our first proponent would be Kyle Kessler, Executive Director, Association of Community Mental Health Centers of Kansas. Welcome back to committee.
Thank you, Madam Chair, members of the committee. I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate the opportunity to appear here this afternoon in support of House Bill 2259, of which we requested introduction. And you have our written comments, and a subsequent conferee will speak to the practice application among medical professionals and how that works and how we think this improves the process potentially. But what I want to speak to very briefly is the history of this bill. In 2016, Senate Bill 123 was introduced, which at the time we had language that protected mental health medications from prior authorization, fail first processes, or step therapy. And that could allow somebody who was on a medication that worked for them to be pushed over to, without that legislation, it would allow someone who is on a medication that would be considered name brand to be pushed over to what is considered a generic medication that might not work the same way for them. Medications affecting the brain are very precise in dose and delivery. And so that was something that we had held fast to for well over a decade, and the legislature had been supportive of. In 2016, we were in quite a budget crisis, and so Senate Bill 123 to eliminate that protective language was introduced. It was defeated in the state Senate. We agreed to compromise language, which established the Mental Health Medication Advisory Committee that has several practicing prescribers on it. And as well as, I think, managed care companies are very involved in it as well. And really, that has not resulted. I think there at that time there was more than maybe a $5 million fiscal note that was put on it that would save money. We've not seen any evidence that any money has been saved by this legislation. And in fact, I would argue that it has cost us workforce time in the amount of time that the prescribers, psychiatrists, nurse practitioners, and others meet quarterly to discuss what adjustments they believe can be made to the prescribing practices. And so they still have to approve any of the changes that go through there. And if they don't like the changes, they don't approve them, and they haven't approved all that much recently. But we see it as a cumbersome process that is unnecessary at this point in time. So with that, I would stand for questions at the appropriate time, and we would request your support for House Bill 2259.
All right. Thank you, Kyle. Appreciate it. Next, I have Dr. Bill Warrens, Medical Director, Association of Community Mental Health Centers of Kansas. Welcome back to committee, Doctor.
Thank you, Madam Chair. Thank you, members of the committee. As some of you may be aware, I am currently a child adolescent psychiatrist, medical director for the association, also medical director for one of our community mental health centers up in northeastern Kansas. I'm medical director for Kids TLC, a psychiatric residential treatment facility in Olathe, Kansas as well. In addition, I've practiced as a family practitioner in rural Nebraska prior to my psychiatry training. And I've also been on the Mental Health Medication Advisory Committee since July of 2022. I started practicing as a child and adolescent psychiatrist in Kansas in 2011. That had been after I had been practicing in Nebraska and then in Iowa. I was surprised when I came to Kansas that I found that there was no Medicaid restrictions in prescribing mental health medications in Kansas. This allowed me to treat my Medicaid patients, which were over 80% of my patient population, with the exact medication that I thought would be the safest and the most helpful for them. But practicing medicine in Nebraska and Iowa had gotten me used to prior authorizations. I was accustomed to completing prior authorizations if I chose a medicine that wasn't on the preferred drug list. I had been told that the primary reason for the medication prior authorizations were to optimize state resources used on this population, therefore to curb the out-of-control rising healthcare costs. The system was relatively functional because the preferred drug list rarely changed and the responses to the prior authorizations were timely. Therefore, the disruption to my practice was minimized. So when Medicaid prior authorization started in Kansas, I felt that I would be prepared. However, both me and my colleagues, both in the PRTF level of care, the acute hospital level of care, and the CMHCs began noticing significant delays in having our prescriptions filled and delays in being notified of a prior authorization. Information given to us was not always clear as to why one of our medications triggered a prior authorization. The communications began occurring via fax, electronic prescription software, phone calls from the pharmacy, and then sometimes phone calls from the panicked parents or patient that we were prescribing for. Sometimes we were not alerted at all. Compliance isn't always the best in mental health, and some patients, when they couldn't fill their medications, just never filled them and never started them. In addition, the prior authorization rules began changing quarterly, making it difficult for providers to keep up with what the rules were for prior authorizations in Kansas. So in our practice, we were having to monitor our patients, our phone lines, our fax lines, and our computer lines to try to see when a prior authorization would be triggered. We were spending increasing amounts of time over lunch hours, after hours, during breaks, trying to fulfill these prior authorizations. Our ability to respond to patient needs decreased, and the number of patients we could see per day decreased. At Kids TLC, the residential treatment facility, there's now one full FTE dedicated just to prior authorizations, and the same is true at the Guidance Center. At the Guidance Center, this is an RN that easily could be patient-facing and supporting patients during that time. But instead, she is focused on prior authorizations. Some of the problems, as I looked into the prior authorizations that Kansas was implementing, I started feeling that perhaps one of the problems was not only we were working on resource management, so for instance, don't use the newest, fanciest medication, use the generic one if it's equivalent. We were starting to mix those prior authorizations with the enforcement of clinical treatment parameters. Now that sounds okay, but the problem with that is if I was treating someone's blood pressure, it's if we're talking resource management, they're going to want me to use the older, tried and true blood pressure medications before I march my way up to the newer blood pressure medications. But if you start throwing the whole class of medications into, are you following the clinical parameters, then it gets a lot more complicated. So for instance, with blood pressure, there's a medication class called ACE inhibitors that are very common. It would be very strange to see the entire class thrown into a prior authorization process where the state and the MCO demand to see the blood pressures and see the lab work that you've done before they're going to approve the medication. I'm not saying that it's wrong to enforce clinical parameters. It's just we've got all of our prescriptions now flowing through the prior authorization system. And so the volume of the prior authorizations, I think, grew maybe larger than what was going to be expected. Not once has a prior authorization, I'm not exaggerating, it sounds melodramatic, but not once has a prior authorization helped me as a mental health prescribing specialist know what a better medication to pick for my patient would be. That has not happened one time, and I haven't heard of it happening one time. So we've got all of these prior authorizations being triggered when the mental health specialty providers are already trying to consider these factors that we are trying to regulate. So board-certified psychiatrists and psychiatric mental health nurse practitioners are the top trained professionals in the country. We're already introspective, we're thinkers, we're deliberating on these clinical guidelines. We collaborate with each other. I'm the co-chair of ks, which is an organization of which we meet every month, all the prescribers for the CMHCs in the state of Kansas. When we break a clinical health parameter for one of our patients, we usually do so purposefully but safely because of something that's unique to that clinical case. When I was behavioral health medical director for Sunflower Health Plan, one thing that impressed upon me, and this should be a good thing, is that I was impressed that the average physician and nurse practitioner in Kansas was skilled. They were aware of all these guidelines, and they were treating appropriately. It was the small minority of prescribers that I think really needed some of these interactions that we're using for prior authorizations. So in the past 8 years, I've used substantial effort to try to protect my patients from Medicaid's prior authorizations. And despite my best efforts, I haven't always been successful. There are many, many patient situations that I could draw upon, but one patient stands out to me. So it was a 9-year-old foster child. I had been treating them at Kids TLC in Olathe in a residential treatment facility. I'd been using a medication for 6 months that the family felt was integral to the stability of that patient. I don't always feel that way about medications. Many mental health situations don't need a medication. But in this situation, it was key to the stability. This patient was discharged from the facility, went to the pharmacy, and couldn't pick up the medication because it was blocked from a prior authorization. I don't believe this is the prior authorization process working correctly. It's just something that happens when you blanket the state with a prior authorization. You have some innocent casualties like this. So the patient aggressed multiple times against their family. The placement was almost disrupted because of this. I was contacted. I was on vacation out in Colorado, and so I was on the phone with MCO case managers. I was on the phone with the family. I was on the phone with the pharmacy. And even so, it took about 48 hours for that medication to be filled, which there were multiple aggressive incidents in that time. So on January 15th, 2023, I became a member of the, on July, I became a member of the Mental Health Medication Advisory Committee. And on January 15th, we brought multiple elements of prior authorization up for a vote. And in every case but one, we passed it unanimously to dismiss the prior authorization, to get rid of it. It was also discussed in this meeting that if future prior authorizations were to be considered, we might want to consider obtaining very specific data on that situation to see if a prior authorization really is necessary, and if so, with what providers. Maybe selected involvement with just the select providers that are having problems prescribing. It was discussed about making the committee more transparent to the public, something that I've heard from external entities multiple times, and the way the agenda being set up is more transparent. All these things I think would improve the functioning of the committee. I believe the rolling back of Kansas mental health prior authorizations, the above changes to MOMAC, while beneficial, speak to the disastrous effects to the mental health prior authorizations of the last few years. If this bill is adopted, I believe that there will be immediate relief for the mental health specialists, prescribers in Kansas. If it's not adopted, then I will continue working on the Mental Health Medication Advisory Committee to try to work towards some of the improvements that I've talked about above. Thank you. I stand for questions.
Thank you very much, Doctor. Next, I have Amy Campbell, Kansas Mental Health Coalition. Welcome to committee, Amy.
Thank you, Madam Chair. My name is Amy Campbell. I work for the Kansas Mental Health Coalition. I've been with the coalition for just in excess of 20 years. We have testified on the issue of prior authorizations for mental health medications many times in front of the legislature. I would hasten to say to you that our testimony today is exactly the same as it was in 2015 and 2017. The issues here relating to prior authorization practices are, just to put it simply, and I am someone who has sat through a number of these committee meetings, what we talk about when we're creating policy in the State House is safety parameters, research-based decision-making, making sure that data is presented. But when we sit in the committee where they are making these decisions, it's very difficult to come up with a lot of practical research data that would support the decisions that are being made. And more often than not, it's more that this is a practice that is occurring across the country, or this has become common, or this is a new medication and we want to be careful before it comes out. Instead of saying that we have a bunch of data about Kansans on the Medicaid program who have been harmed through the prescribing of these particular medications, and therefore we should do something about it. And so just to put my testimony, kind of wrap it up in a little package, when we have Mental Health Advocacy Day at the Capitol, invariably I am encountered by a family member of someone whose medication was stopped, maybe by Medicaid, maybe by commercial insurance, maybe by someone else, and the negative impacts that that has on that family and that individual. So what we advocate for are safety-based policies that are less about the financial costs of a particular product and more about the fact that we have seen harm because of prescribing practices that are already happening, and we would like to see people kept safe from those poor practices. That just isn't the way that this system is set up. I want to be clear that this isn't any sort of a negative reflection on the Kansas Department of Health and Environment. This is a process that was set up by the Kansas Legislature, and in our opinion, our testimony remains the same, that we don't think that prior authorizations under Medicaid are a good way to proceed. Thank you, Madam Chair.
Thank you very much, Amy. Then I've got Madison Elliott, Public Policy and Advocacy Director of NAMI, Kansas. Welcome to committee.
Thank you, Madam Chair. And thank you all for the opportunity to provide testimony here on behalf of NAMI Kansas, our members, and all of our local affiliates across the state as well. So we are a proponent of House Bill 2259. We support both the elimination of restrictions on mental health medications for Medicaid recipients, as well as the abolishment of the MOM Act, for multiple reasons, some of which I've included in testimony and we'll share here. So most of the time restrictions, such as step therapy, prior authorizations, they're implemented as cost-saving methods by insurers. And while there's evidence that this can decrease medication cost spending, there is also evidence that it increases the likelihood of mental health hospitalization, and it increases the odds of imprisonment for folks with mental health conditions. So it likely would increase spending in those areas. Additionally, providers in multiple studies indicate that prior authorizations increased administrative burdens, delayed patient care, and increased negative clinical outcomes for their patients. So especially with workforce issues that we've commonly been discussing in Kansas, we see the negative effects with these restrictions there as well. Additionally, there has been more enforcement in multiple other states regarding the Mental Health Parity and Addiction Equity Act. While that's been in place for a while, the actual enforcement of compliance with that act hasn't been great, and now we are seeing increasing enforcement and studies on how insurance providers are actually abiding by that. And so requiring the elimination of prior authorizations and other restrictions on mental health medications decreases the likelihood of any parity violations. Additionally, it decreases documentation that these insurers would need to provide to demonstrate compliance. And if they were to be found in violation of any violations or of any of the components of the Mental Health Parity and Addiction Equity Act, they would likely have to pay fines on that. So that would be an additional cost there. I have also had one of our members submit testimony, and she has submitted that as written testimony, but she has lived experience, and I'd be happy to share that verbally if that is desired, and I will stand for questions at the appropriate time. Thank you.
Thank you very much. Appreciate it. Okay, committee, then we have written only from Donita McDonald, private citizen, and we'll go ahead and I'm going to go ahead and go to our opponents, and then because we only have one, and then we'll open up questions to both sides. So the opponent is Sarah Fertig, Medicaid Director, Kansas Department of Health and Environment. Welcome to committee, Sarah.
Thank you, Madam Chair. Good afternoon, committee. My name is Sarah Fertig. I am the Medicaid Director for the state of Kansas. I work for the Kansas Department of Health and Environment, and KDHE is an opponent for this bill today for two kind of general reasons. Number one, we feel that this bill would roll back some really valuable and meaningful reforms that the state has been implementing since 2015, that have led to improved safety in terms of mental health medication utilization by Medicaid recipients while lowering cost. And we also have concerns that eliminating the ability of the state to have health and safety related edits for mental health medications could come at a cost to patient safety. So we did provide some written testimony today. Kyle Kessler provided a little bit of a background on how the MHMAC, or MOMAC, as some of the conferees call it, came to be. But essentially, this came about in around 2015, and it was really a compromise, as Mr. Kessler pointed out. It was really a compromise. The state agencies operating the Medicaid program had identified some troubling prescription patterns and overuse of antipsychotics, particularly among Medicaid kids under age 17, particularly in the foster care population. And so they sought the authority to impose some of these restrictions for mental health medications for the Medicaid population. Our written testimony includes a link to KDHE and KDAD's joint testimony from 2015 in support of that bill. And so it's been around since around 2015. And the MHMAC is comprised of physicians, APRNs with mental health expertise, physicians. One of the proponents, Dr. Warrens, is on the MHMAC, and their job is really just to review suggestions for prior authorizations and other restrictions on mental health medications. And their recommendations go to the Drug Utilization Review, or DUR board, and the DUR board can either vote them up or vote them down. There's no amendment. So we feel that the structure is good. It strikes a good balance between making sure that that mental health expertise is there when crafting prior authorizations, but also making sure that there is oversight. And those meetings are all open to the public. So in our testimony, we highlight some of the concerns we have about this bill if it were to be enacted. And first and foremost, we do have some concerns that if enacted, this bill would reopen the door to some dangerous prescribing practices that we saw in the early 2010s. And at that time, KDHE and KDADS observed pretty troubling rates of use of more than 3 antipsychotic medications at one time by kids on Medicaid. And that was one of the reasons why they sought the authority to impose those restrictions. Now, to be clear, I'm not suggesting that Medicaid providers were engaging in dangerous practices. However, without the ability at the payer side to see that a child is receiving multiple antipsychotics at the same time, we're lacking that backstop against overprescribing. You know, we do recognize that there are instances where a practitioner might not have the patient's complete drug history and might inadvertently prescribe an extra antipsychotic when they're already on multiple. But we feel like having that backdrop of oversight on the state side is important. And so what we've seen from our review is following the enactment of the legislation that created the MHMAC and allowed the state to have health and safety edits on mental health drugs, one MCO saw huge decreases in the number of kids under age 17 taking multiple antipsychotic drugs concurrently. They saw, over a 2-year period, they saw that drop from about 40,000 of their members down to fewer than 30,000 of their members. And our concern is that we know if we no longer have the ability to impose those health and safety edits and prior authorization requirements, that we might go back to those earlier numbers where we have more and more kids on Medicaid taking multiple antipsychotics at the same time. We also heard from one of the conferees concerns about parity, mental health and medical drug parity. Another concern we have is if this bill were enacted, it would remove the parity that currently exists in our drug coverage. So this bill would apply only to the Medicaid program and only to mental health drugs covered by the Medicaid program. So if you're on Medicaid and you have asthma or hypertension or migraine, your drugs would still be subject to prior authorization requirements as approved by our Drug Utilization Review Board, but only mental health drugs would escape all of that review and all of those health and safety and cost controls. So we have some concerns there that we would be carving out only mental health drugs and only for Medicaid by this bill. It wouldn't touch private payers and it wouldn't touch any other classes of drugs that Medicaid covers. I would also add that we're already working to try and reduce the provider burdens. I think Dr. Warrens testified to this, talking about some of his experiences in being a provider. He also mentioned that as recently as January of this year, the MHMAC has been passing through changes to our current prior authorization processes to streamline them and make them less burdensome for providers. Our concern is that if this bill passes, we're going to short circuit that work that's already in place and kind of throw the baby out with the bathwater rather than continuing to make improvements where we can. We already have more discussions on how to streamline this process planned for 2023, this bill would short circuit all of that. And then lastly, we'd like to point out that it's the view of the Medicaid program that the restrictions we currently have on mental health drugs are reasonable and they're clinically sound. Again, when you're talking about prior authorizations for mental health drugs, there are two levels of protection that are applied to those drugs. They have to be reviewed and recommended by the Mental Health Medication Advisory Committee, and then they have to go to the full Drug Utilization Review Board. So they're reviewed by two separate panels of pharmacists, physicians, APRNs with mental health expertise, psychiatrists. So that protection is there. So by the time they're in place, they're reasonable and clinically sound. One of the prior authorization requirements we have is a general policy that when a generic drug is on the market, if a generic option is available, the member has to use a generic drug rather than the prescription or the brand name drug. And the reason for that is really cost containment. You know, these are identical formulations for the drug. Let's use a generic one first. In our written testimony on page 3, we've got some charts here that I think really call this out very, very clearly. And really what this is highlighting is that the vast majority of drugs, mental health drugs used by Medicaid beneficiaries are generic. All of this orange here, that's generic. Few of them are used under brand names. However, the vast majority of the drugs spent dollars are on the brand name drugs. So the generic drugs only occupy about 88% of the mental health scripts that are filled for Medicaid members, but they only comprise about 17% of the drug spend. So a lot of bang for little dollars. Just by way of example, you know, if you were to have somebody with a new depression diagnosis, the doctor prescribes something akin to Prozac. Brand name Prozac costs about $500 a month. The generic is less than $25 a month for the same chemical composition. So our concern would be that this bill would eliminate our ability to have that generic drug requirement. We also do have some step therapy policies in place whereby a patient is generally required to start with a frontline, established, cheaper drug before moving on to a more expensive drug. You know, the kinds that you see advertised during the Super Bowl, those tend to be quite expensive. This bill would hinder our ability to continue to impose that requirement. And so generally, we would oppose this bill because largely due to concerns about health and safety. We would also point out there was a question about a fiscal note. We do have a fiscal note on this. KDHE's fiscal note estimates about $7.1 million annually. That does not include any additional costs that would come around if we were required to undo the generic drug requirement. We weren't able to quite calculate that, so that is a starting point for what the fiscal note would be. So, Madam Chair, I can pause there. I'd be happy to stand for any questions.
All right, we're going to take questions from everyone, so we'll see where we get. Committee, that ends our conferees at this time. So questions, comments for the conferees? Representing Burkamp.
Thank you, Madam Chair. This is for Sarah. And I don't know much about this, so you'll have to bear with me. How much data is available to you to look at from the Medicaid side as a state? I see your charts here, but I don't know if you could see any more detail than that, or if it's pretty high level as far as like what's happening at the physician level.
We do. Madam Chair, we have a great deal of data. So think of Medicaid kind of like a giant insurance company. That's kind of what we are. Our MCOs pay claims for all of the drug spend, and then they submit information about each of those claims through what's known as encounter data to the state. So we know who the patient is, what they were prescribed, the dosage, we know who the provider is, we know all of that.
So I guess maybe with that known, would it be possible to use the data to kind of be the oversight without having the oversight committee, so to speak? I mean, can't you use the data without having to have the oversight committee, if that makes sense?
Madam Chair, I need to think on that for a second. Well, I'm not sure that would be sufficient for all drugs. So we've got new drugs coming on the market all the time. Obviously, we wouldn't have data on that if, they're just getting off the ground and that's just starting to be prescribed. That's one of the charges of the MHMAC and the DUR board, to continuously review new drugs coming on the market to see what, if any, prior authorization requirements would be appropriate there. So that wouldn't solve the problem with those, but the work that the MHMAC and the DUR board does is informed by what our staff is seeing in the data.
Okay, thank you.
Representative Bueller.
This is also to Sarah, and I might be a little biased because I'm married to a pharmacist, but when I think of the organization or the MAC, whatever it is, how you pronounce that, to me that just seems like that is a hindrance between a doctor, a patient, and potentially a pharmacist. What I hear is cost control. But we had a doctor up here talk about taking 48 hours to get past a prior authorization. And I know from my wife's professional experience how frustrating those are for someone who either needs medical care or, in this case, mental care. What differences or what improvements could you make or persuade us to say, hey, this is how we add value, other than just being a stopgap or a cost containment? Because that's what I hear, and I don't mean to be overly biased, but that's the way I interpret it.
So Madam Chair, that's a great question. Thank you very much. So, Madam Chair, I think what we would say is that what this bill would do is abandon that structure entirely and open the door to any and all prescription with no state oversight. We don't think that's the answer. We hear from our stakeholders and providers all the time on recommendations on how to improve what the MCOs are doing. They're not shy. They come to us with complaints all the time. This is a new one. This is not one that I've heard. But I think there's other avenues for us to address those complaints. We meet with the MCOs twice a month. We can bring up issues like this. When we receive a complaint that things are taking too slowly, in some areas, we hold the MCOs accountable and ask them to chase it down. We're just not sure this is the answer to those types of questions.
So if I may, just one more question. So let's use an example. So if there is a particular drug that works, that either the mental health provider knows, or in this case a mental health provider knows, that works for a patient, and they can't get that, what avenue do they have? Because that progression that you're talking about simply is not care. I mean, it's not sufficient care. So what avenue do they have when a doctor knows there is a medicine that the prior authorization is required and they can't get? What is the avenue for them to fix that?
Madam Chair, with your permission, I would like to phone a friend. With me today is Annette Grant. She is our pharmaceutical programs manager, and she's a pharmacist, and she could speak to those details better than I could. Madam Chair, is that okay if I call Annette up? Okay. Annette.
Hello, Madam Chairman and the committee. Yes, I'd like to
Annette,
speak to that.
I just need you to state your name and who you're with. I know you haven't been before us, but that's what we do because of our online process.
Yes, I believe, if I know the situation that Dr. Warnes was talking about, that was a patient on a medication they had, and it was a renewal that came through for renewal for PA. So they already had it, and they'd already been allowed to be on it, but the renewal came up. And so one of the things we actually did change in this January meeting was to remove renewal requirements. All other disease states have a renewal requirement, but in this case, our renewal criteria were kind of passive and not really impactful anyway, so we removed the renewal requirement. So going forward, that wouldn't happen again because, again, they are already on the medication. We don't see a need to have any renewal requirements like we did before. So that is resolved. If you talk about a brand new drug, the doctors do not necessarily know that absolutely is going to be the right one that time. They're going to try them on it, right? And that's where initial 24-hour, if there's a drug with a PA, we have to resolve that. We have to get back to the provider within 24 hours. So I'm not sure why that took 48 hours. I have no idea, but our CMS requirement is 24-hour response to a PA request. But again, so there's the difference between a brand new drug that they're not on yet versus something they've been on, and the renewal, which in this case we removed the renewals for all the mental health medications this last time.
Thank you. Thank you, Madam Chair.
Thank you.
Representative Reese, and I believe it's for Kessler. Is that right?
Yes.
Kyle Kessler, excuse me. Just be happy I called you.
I go by both names, Madam Chair.
Thank you, Kessler, for coming.
Yes. Thanks.
I too am concerned about the use of antipsychotic medications on children. I do remember in 2015 and prior to that, an overuse of that, using chemical restraints by prescribing antipsychotic on kids. I'm concerned that we don't have enough guardrails with that, with removing, the oversight that we're kind of seeing now, and I understand that's too restrictive. What if anything could be offered in order to add some guardrails here to ensure that they're not overprescribing antipsychotic, especially to children?
Yeah, and Representative, I think that's absolutely an imperative question to ask, and knowing some of the history of this issue, I know that the majority of prescribing practices for youth and adolescents is off-label. A lot of that has to do with the lack of research and development in the psychiatric space over time. So technically, an MCO would be able to flag that kind of stuff regularly if it wasn't for the Mental Health Medication Advisory Committee, and Dr. Warrens would probably be good to speak to this too. I mean, right now, there's nothing that prevents an MCO from flagging and taking a bad prescriber off of their panel if they want to do the work to drill down into that data. I've heard some of the data that one of the previous conferee for the first time today, and it's not because they couldn't give some of that data to the MOMAC, which would then give that to us as well. So I think that that's something to consider, and we really would push educational policies. And we've always said that there's nothing that prevents the MCOs from doing that work. They just wanted to sort of turn off the spigot and move really quickly towards the fail first policies that have failed essentially in other states.
Thank you. Representative Clifford.
Thank you, Madam Chair. Dr. Warrens, still in the room? Yes. So does this board work with the MCOs or with the Medicaid director to establish protocols for these drug steps?
The MCOs have a presence at the meetings, and they're able to provide input. Maybe if I could get a little bit more clarification on your question.
Well, beyond the cost containment use of this, to me, it is non-physicians, non-medical people practicing medicine. Do you perceive it that way?
I would say one thing that's happened in the first few years of the Mental Health Medication Advisory Committee is that it was a new process. And while there was physicians involved, I think maybe no one on the committee and maybe no one at KDHE quite realized the damaging effects of the prior authorizations in their first go-round of trying to regulate the medications. And so I do feel like they are getting physician input and they are scaling back to try to figure out what would be a new way to try to regulate medications a little bit safer than what's been done before.
Well, like you, I mean, I and my staff waste a considerable amount of time seeking prior authorization. So, my bias is to get rid of this. Are you saying the process is evolving appropriately where these things, these problems for our patients aren't going to show up?
Well, that's a tough one for me to answer because we're on the heels of some damaging policies, I think. But we've reversed a lot of those policies here recently. I think there's been talk of many things that can improve this process, like increasing the transparency of the meetings, how the agenda is set. I'm on the committee and I don't know how the agenda is set. The data that KDHE is showing, I think the members of the committee would love seeing that data. We'd love to be data driven in how we create these rules. I also would love in my practice to shorten these prior authorizations. If you want me to use another medication before I use the medication I want, give me a checkbox and a signature and get the response back to me within hours, you know. When we fill out prior authorization processes, I feel like I have to fill out my own demographics. I guess I'm cross-checking it for the MCOs to make sure it's up to date. I've got to fill out all the patient's demographics and then all this clinical history, not even knowing through the communication always why there was a prior authorization, so I can just cut to the chase and say, okay, we'll do this, or we've done this, and to speed up the whole process so the patient can get the medicine much faster than what's currently happening. So I mean, there's potential for the future. I do think there's potential for the future in improving the processes. It's just tough to ask me that now with the situation we're in right now.
So the process is cumbersome, the process is slow, and it tells you as a physician to do something other than what you think is the best for your patient.
Many times I believe that's correct.
Thank you. Thank you, Madam Chair.
Representative Barth.
Thank you, Madam Chair. This might be partially for you and then maybe partially for Sarah Furtick as well. So I'll start with you on it. So I'm on another committee too, social services budget. And one of the things, we had a pharmacy review budget that came up. And one of the questions I had asked, and Sarah Furtick sent me a lot of information. So I'm reading an email that she sent to me. So this is actually helpful for this conversation today. So we do have a convoluted process. Actually, there's quite a few layers, which I know there's some probably good in that, because I'm concerned about when I'm looking at the fiscal note, why are we raising a note when in my mind, it should be coming down in costs. So we have what's called a Medicaid prescription drug list, because usually you have a formulary that's something that we have that lists out what does the state has approved drugs that will cover, you know, for different tiers and needs as well. So there's that, which you need. But then we also, Medicaid also receives directions on prescription drug policy from the Drug Utilization Review Board. So there's another layer there that's also included. And I don't know, I'll keep going, but that's kind of a question. Is that Kansas or is that federal driven? And then we have the Mental Health Medication Advisory Committee, this one that you're talking about, the MHMAC, which is a statutory created body. And it provides this function is to provide to the DUR board another layer. So there's lots of layers to the layers. And I think too, like the prior authorization, if we have a way, you go to the pharmacy, you pick up your drug and it says, oh, well, we didn't do a prior authorization, but you actually aren't qualified for this because you haven't tried, you know, name the first more cheaper, less expensive generic drug first. I don't know if there's a way we could do that, but it seems like we could come up with a better solution. So I think I have a few little questions in there, but also just some food for thought as well.
I think there's a lot of worth in what you said. I mean, I think there's a lot of things you're touching on that make a lot of sense.
Okay. Thanks. And then do you want to, if Sarah, if you wouldn't mind, thank you.
So, Madam Chair, yes, so there are multiple bodies that help govern how the state establishes the preferred drug list for Medicaid and how prior authorization requirements are imposed. And some of that is set by federal law. So under federal law, we have to have a drug utilization review board. So the DUR board, it's in state statute, but it's also required under federal law. The MHMAC, that is purely a state statute creation. And PDL is, Annette, is that a federal requirement for a PDL? State requirement? Yes. So state requirement for a preferred drug list.
And can you, if you wouldn't mind, just explain the math of how you came up with the additional millions of dollars for the fiscal note on the changes that would be made with this bill that would eliminate prior authorization? To me, it seems like it should come down, not go up. Can you help me with that?
So I'll speak to some of it, and then once again, Madam Chair, with your permission, I'll ask Annette, since she worked on a lot of that. Some of the loss would come from supplemental drug rebates that we get. Drug manufacturers we're allowed to negotiate with drug manufacturers for drugs that are safe and efficacious and cost-effective for placement on the preferred drug list. They pay us a supplemental drug rebate in exchange for that. So there is some revenue loss that would be associated with that if we were no longer allowed, because that is a form of prior authorization. having a drug on the preferred drug list. 'Cause you're expected to start with a drug on that list. So if we were no longer allowed to do that with the mental health drugs, there would be a loss of drug rebate revenue. And Madam Chair, is it okay if I call Annette Grant up again? Okay.
Just make sure you tell us who you are when you step up, because of
Sorry.
WebEx.
Annette Grant. So to answer that question.
With KDHE?
KDHE, my apologies. So that fiscal note was based upon any cost-saving edits that are in the prioritization criteria. So the prioritization criteria largely are maximum dose and a maximum multiple concurrent drug use. So those are the safety edits. But then there's cost-saving edits in there that we've just started probably in the last year and a half, step therapy. So if there's a first-line drug, a drug that's been out there for a long time with known side effects, lots of use, so we know a lot about that drug, we require that drug for that indication to be used prior to a newer drug for that indication. So that was a comparison of any of our PAs with step therapy, the drug that has to be stepped through against the drug that that's being requested, that cost difference, and the number of, and the claims data that accounts for the number of claims times that dollar difference. So that was figured for any of the PAs with step therapy and any of the PDL classes. We have some of the mental health drugs on PDL, so that was comparing the most expensive drug in that PDL class against the least expensive drug in that PDL class, and that was the cost savings there difference. So any PDL class for mental health. And then we do have one of the ADHD drugs that we have on PDL does have a supplemental rebate. We probably would get those for antipsychotics, but we don't have those on the PDL. So we have addressed any of that through the committee. But anyway, it's based through step therapy and PDL. Thank you.
Representative Bueller.
One more question. So when it comes to I was following you in terms of how you were calculating the losses or in that way. Mm-hmm. So how would that compare to the data before pre-2015? Do you know the difference before the board? Are we actually, do you have data that would say this is something that you have estimated to be a cost? Do you have actual data pre-2015 that you can compare the two?
No, we've not compared the two.
Okay, so it's not an actual.
It's because I know in the original data there was a lot of most of the antipsychotics were brand at that time, and so now they're generic. So it's kind of flipped, but still, even as Sarah was saying earlier, the newer drugs are very expensive and they're going up roughly 5% per year. So it's not apples to apples in that case.
Okay, I appreciate it, and I realize it's going to be tough to make a comparison. I'm just trying to get my head around. What was the cost to this program pre-2015 actual cost compared to what you're projecting the cost to be? So there's going to be wiggle room both ways, it sounds like, if I'm interpreting correctly.
Right, and I think that's a good question, but I think the biggest thing take home on is that we have been making progress with this committee and we see only good things going forward. So personally, I'm a little discouraged because I think of all the good things we want to do with this committee and to make it better and even to make it more of an opportunity for stakeholders, PRTFs, the psychotropic work group to come and speak and think about how we can use this as a venue for collaborative work. So we're on our way to better, like Dr. Warrens was saying, when the first committees first started, there was just that learning curve, and there's things put in the PAs that the committee agreed with, but then the burden was too great, so we moved those out, and it's just been there's been learning curve, but I think it's really progressed well, especially in the last year. So I would hate to see all that value be lost.
I appreciate your comments, and I wasn't coming across as combative. I was just trying to compare the two. Thank you, Madam Chair.
Representative Epley.
Thank you, Madam Chair. This is for Dr. Warrens, if he doesn't mind popping back up, please. Thanks a lot, Dr. Warrens, for coming back. And, you and I look at this very similarly, I think, and I'm real conflicted with this because we're dealing with state funds and state monies. And I know for a fact, having dealt with this as a provider, that the committees function much more dynamically than they used to. They're functioning better. Would you better than they did 6 or 7 years ago? Wouldn't you agree to that too, having served on the committee?
I would.
And on the turnaround time, what would you say the turnaround time is for prior authorizations now through the Medicaid MCOs? I know it's better than it was. What are you experiencing as a provider? I think you need to share that with the group if you don't mind.
Well, it's difficult. It's difficult because there's a wide range, but it's not uncommon for us to start a week working on a prior authorization and still be working on the prior authorization at the end of a week.
So it still drags out quite a while sometimes?
Yes, it does.
And okay.
Now some of that may be the provider's fault. We're trying the best we can. As I don't want to blame all the MCOs and everything for things that might be our fault, but the system, that's kind of how it plays out.
And I understand that, and I think we'll ask the pharmacist to come back up in a minute and comment on that. So, but the other thing that I think the committee needs to understand, we are dealing with state funds here, and whatever financial note is put forward, you and I both know as physician minds, we want to give the absolute latest, greatest med to our patients, generally speaking. Wouldn't you say that's true?
Well, I mean, I guess it depends. Maybe it's just the way I was raised or whatnot, but I do think I have some fiscal thoughts running through my head when I prescribe for a patient, and do try to, if all things are equal, do try to go with a medication that costs the state less, unless it's trumped by something that this new medicine does that's better than the generic.
Would you say that you're the norm or the exception to the frugality issue?
I don't know.
Yeah, because I just know physician brains, we want to use the latest, greatest meds sometimes. And while it's been set at $7.9 million, I think in the note that I saw, I think into the future it could be a lot more of state monies going for non-generic drugs and getting away from the drug utilization. So I'd ask our pharmacist from KDHE to come back up and just comment about what we're committed to on turnaround time on prior auths at this time through the committee.
Sure.
And restate your name, pretty please.
Sorry. Annette Grant, KDHE.
Thank you.
Thank you. Yes, it is a seamless requirement that we respond within 24 hours, and that response could be approved, denied, or needs more information. So that's a requirement, and we actually do track that at the state. Once in a while, we'll see where an MCO has gone over the 24 hours, and that's usually they sent, like it had to be escalated, and like the first person said, I think we need to deny this, so then it's got to go to the physician on their plan, and they might have submitted it to the wrong person, and so they'll put that down. You know, it got submitted to the wrong person, that's why it took more than 24 hours, but that's not very often at all. So I'm really surprised to hear that. Now, if it needs more information and they don't receive it within 5 days, the case is closed. So that's my experience.
One last question. Don't you feel like there's been some learning by some of your psychiatric and providers that provide psych meds, learning in what meds they should use versus what they would like to use that costs a lot more? I mean, that they learn to go with the generics early on rather than trying to prescribe the latest thing?
Yeah, I think that makes more sense. And if you prescribe the preferred drug at the right dose and it's not exceeding the multiple concurrent, you can bypass some of that. And what we did this last meeting was try to make sure that was possible. So remove the renewal requirements, and then we did remove diagnosis code because that would stop a drug at the beginning. I require a diagnosis, which that is a safety edit, but without, okay, we'll let that go. So now, going forward, if you write a preferred drug, the right dose, and you're not exceeding multiple concurrent, the number of PAs at the get-go should dramatically go down. And then, like I said earlier, we removed a lot of the renewal PA requirement, which all our other PAs have that, but we removed it for mental health drugs. We really feel like there should be a huge decrease in the number of PAs for mental health medications.
And then just into the future, as a pharmacist, do you know how much drug, you said 5%, but some of these biosimilars and things that we're using in the psychiatric world are extremely expensive. And so we're playing with house money here for patients that are on Medicaid MCOs, and I think we have to be frugal, or we have to be responsible for that. And doesn't that concern you into the future?
It
with
does.
The cost
and
of meds these days?
I've said before, if we can treat 5 people with a $1 drug, we don't want to turn away 4 people to give one person a $5 drug. And so, again, I think we're making strides in this committee, and I'd like to see us be able to progress by having the dialogue. And we do listen to the providers, and that's why we're making changes, because you don't always know the impact of things, but when you learn, you fix things.
Thank you.
Mm-hmm.
Thank you, Madam Chair.
Committee, any other discussion? Comments? You do.
Can I have one?
Representative Turner.
Thank you. Quick question. The this for Sarah. I think I heard when you were up speaking, and it sounds like this, you give a nice recount in your testimony about this came about in 2015, and we've heard a lot of talk about how it's continuous improvement. But I thought I heard you say that this is the first you've heard of this issue. Did I hear you? Did I say that?
So,
or I hear that? I'm sorry.
Yeah, Madam Chair, some of the concerns that we've heard expressed today were the first time I've heard about it, like delays in prior authorization turnaround times. I think we would have preferred to have a discussion on ways that we can continue to improve the way that MHMAC works. So the legislation came as a surprise, yes.
Thank you. And so what is the normal avenue which these kinds of concerns would rise to the board for action?
Sure. So, Madam Chair, our stakeholders have a number of ways to interact with the state and the DUR board and the MHMAC. They have their regularly scheduled meetings. They're open to the public. We have information posted on the KDHE website. Anyone who's interested in participating can. We also have other avenues. We have monthly stakeholder calls. The CMHCs, we meet with them monthly separately. So we have an open door. I have people emailing me all the time. If a hospital is upset, if they feel that prior auths are being turned around too slowly, trust me, they have my email address and they reach out constantly. So, we try and keep a very open door for providers who have concerns or if they have recommendations on how to improve Medicaid. So, yeah, when things come up that I haven't heard of before, it's usually a surprise because our door is open and we hear about things regularly. We try and provide ample opportunity for our providers to express concerns to us.
Thank you for that, and thanks for your testimony.
Any further questions or comments? All right, seeing none, committee, that will close the hearing on House Bill 2259. And because we've got someone that's going to be absent tomorrow, we're going to do something a little bit unusual today. We're going to go ahead and work House Bill 2340, which is the BSRB bill.
Madam Chair, I would like to move that we pass out House Bill 2340 favorably for passage.
Seconded by Representative Reese. Comments, discussions? Representative Bergquist.
Yes, ma'am. Could we have a brief review before we take action from the reviser?
This is the one we just heard yesterday. Do you need to go over it? Because the only thing is we're just running out of time. We've got two more people to do, but this is the change on the BSRB, some licensing and some registrations and times to expedite workers forward.
Okay, I've got it. Thank you.
Okay. That's your first. Representative Reese, we can get you something on it. We're not going to wrap it up. No, we're not going to finish it all up here today. I just have Representative Reese is not going to be able to be here tomorrow, and she has a couple of amendments she'd like to run herself. So we're going to answer your question.
Thank you, Madam Chair. I'd like to offer an amendment, and that is to strike the requirement of the cultural diversity. I think I need the other one. I'm not sure it's that one, the one you have.
Reduce the diagnostics.
Yeah.
Profession licensed by the board.
I need it. I need the other one. There's another one.
Thank you.
That's it. I don't see where it says the. Okay. Just take it here. That's the first one.
The first part of this amendment.
Yes. That's the first part of this amendment. And that would also reduce the need for the continuing education in diagnosis and treatment from 6 to 3, since we're striking the 3 of the from the cultural diversity requirement. And that would be true for all the professions licensed by the board.
Going from 6 to 3.
Yes, going from 6 to 3 for the diagnosis.
Is there a second on the Reese amendment?
Clifford seconds.
Representative Clifford seconds. Discussion on the amendment.
Yes.
Representative Ellis.
Why from 6 to 3?
I don't. Is your mic on?
Yes, I think. I hope.
There you go. Closer. This one you may have to eat that one. I don't know.
Yes. Why 6 to 3?
Currently, there are 6 continuing education requirements for diagnosis and treatment. In the bill itself, it reduced the 6 to 3 for diagnosis and treatment, and 3 for the diversity, for the cultural, the cultural diversity piece. So taking away the cultural diversity piece only leaves 3 for the diagnosis and treatment.
Thank you.
In other words, they lost 3 clinical hours.
Yes.
Other comments or questions? Representative Blex.
Thank you, ma'am. And just speed reading it, I know we want to get done. It looks like the cultural diversity is stricken in all throughout the bill.
Yes, it is.
Correct?
It is.
Thank you, ma'am.
And just so you know, tomorrow when we come back, if you guys see something in this that you kind of percolated with over the evening, we can discuss it again. This is a little bit of an unusual procedure here, but I want everyone to feel comfortable with what we're working and what we are passing out. So, is there further discussion or comments on the Reese amendment? Representative Barth.
Just one question. For my notes that we took yesterday, I had that originally it was 3 hours of ethics and 6 hours of diagnosis and treatment, but their change was to go from 3 hours of ethics to 6 hours of ethics, and 6 hours of diagnosis to only to 3 hours. So
no,
that's what I had in my notes from yesterday.
Okay, but that's not what it did.
Okay. So you're saying that it's going to still have 3 hours of ethics and
3 hours of clinic.
Okay.
So
All
they
right.
lost
Just
3
wanted to
hours of
clarify
clinical
then.
because it was 6 hours of clinical is what it was.
Thanks.
So we thank them for making that move for us. Further discussion, comments? Blex. Representative Blex.
And Madam Chair, wasn't reducing that 6 hours and down to 3 would actually put us more in line with some of the surrounding states. Am I correct in remembering that?
I believe you're correct, but I'm not going to vouch on that
Okay,
right now.
thank you.
You don't want to operate off my memory on some days up here. Further questions or comments on the Reese amendment? Representative Reese, you may close.
I move my amendment.
You've heard the motion by Representative Reese to amend, seconded by Representative Clifford. All those in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Representative Reese.
That one's done. Done.
I offer. Thank you, Madam Chair. I'm offering another amendment. This amendment is on page 15. Page 15, line 10. And it's reducing the 15 credit hours required to 3 and leaving the requirement of having to take the psychopathology course. Psychopathology, that's typically a 3-hour course, so it would leave that, reduce that from 15 to 3 and only leaving in the psychopathology course. And if you go down to to section C, line 17, it would be adding, on line 18, it says including and adding but not limited to psychotherapy and assessment, integrating diagnosis, and let me take this off. On line 19, integrating diagnosis or diagnostic impressions. We'd be adding that language. If you go down further to line 28, contact, including but not limited to. Again, we're matching the language from Section C down to line 29, families or groups integrating diagnosis or diagnostic impressions. Again, that's matching what I've changed in C.
Is that it?
That is it.
Is there a second on the Reese amendment? Second by Representative Epley. Questions or comments on the Reese amendment? Representative Ellis.
Why, just my own understanding, why from 15 to 3? It's not needed, or?
Representative Reese.
The 15 credit hours, that is all already in coursework. So when you graduate with your master's, that's all there, but you have to have the course in psychopathology in order to be able to diagnose. So that remains, but that only needs the 3.
Thank you.
Further questions or comments on the Reese amendment? Anyone else? Questions?
Don't see any.
Representative Barth? Question?
Thank you, Madam Chair. We were just discussing, we weren't quite sure. I was asking him if he knows. So the change that would go on to line 29, where it's integrating the diagnosis and diagnostic impressions, and you spell out that it's the American Psychiatric Association's Diagnostic and Statistical Manual. There's no information exactly what that entails that we're including, so can you give us a little bit of information on why you put that in there, what exactly that is?
That was already in the language in statute, so that is what is called the DSM. And so it is the, put it simple way, it's a guide, it's the guidebook under which you can diagnose. It's got the codes on it. It's very extensive, but in that you learn all about the diagnostic or learning about the DSM when you take the psychopathology course.
Go ahead.
You said it was already in there. Can you please show us where it is already in there?
In the bill? Would that be in the bill,
statute?
Scott? Line 34 on the same page.
Oh, so it's, okay, I see now. Thank you.
You're welcome. Any further questions or comments? You look like you have a question down there, do you? Oh, okay. She's so quiet down there. Any further comments or questions? All right, committee, seeing none. You've heard the motion by Representative Reese, seconded by Representative Epley. All those in favor signify by saying aye.
Aye.
Opposed, no. The ayes appear to have it. The ayes do have it. Motion carries. All right, and the reason like I said, there's more amendments I know that are coming. Representative Reese cannot be here tomorrow, and she was wanting to take care of those today. So what we're going to do is do I have to recess or can I adjourn? Okay. We're going to adjourn until tomorrow at 1:30. We will be hearing House Bill 2390, but I think what we'll do is we're going to wrap up on the we'll decide what order it is tomorrow. We are adjourned.